Now moving on to our next section, that is the fracture scaphoid. In this section, we will be discussing the fractures around the scaphoid bone, what is its mechanism of injury, pathological anatomy, clinical features, and x-rays. And lastly, we will be discussing how to treat the fractures of the scaphoid and what are their associated complications. Now, the most common fracture on the wrist joint are actually the fracture scaphoid. They account for almost 75% of all the carpal fractures. Although rare in elderly or the children, usually the mechanism of injury and the is such that this results in a fall on the outstretched hand with the wrist is slightly in extension and there is radial deviation of the wrist joint. Therefore, the loading mechanism is such the maximum loading is actually occurs at the radioscaphoid joint. Usually, as you know, the scaphoid lies obliquely across the two rows of the carpal bone, and a combination of forced carpal movement, that is actually there is a radial deviation of the wrist, slight extension, and then the patient falls like this. The maximum tenderness is on this joint, whereas the radioscaphoid joint, and this usually results in the scaphoid fractures, and that is why it's the most commonly it's fractures, and it's the tenderness it can be palpated in the anatomical snuff box. Now the fractures in three anatomical locations, which is important. As you know, the scaphoid is lying obliquely, so it has a dorsal pole, which is lying over the dorsal surface. It has a proximal pole and a waist. Now distal tubercle is such that it is actually the main arterial supply to the scaphoid is coming from the distal tubercle, then going retrograde towards the waist and the proximal tubule. So waist and proximal pole does not have a blood supply of its own, and that is a very important concept because that is when we are discussing the avascular necrosis of the scaphoid, this concept comes into play. Some fractures are unstable. Usually they are distal oblique fractures of the wrist joint, and they may be disposed to non-union or malunion. Why they are unstable? Because usually the blood supply is coming retrogradely from the dorsal surface or dorsal tubercle. As the artery descends down in dorsal fractures or dorsal pole fractures, this usually results in disruption of the blood supply. Once that happens, the waist and proximal pole are also become avascular because they're already getting the blood supply from the dorsal surface via retrograde flow. So that is why these are unstable fractures most of the time. Blood supply, as I told you, the blood supply of the scaphoid arises from the dorsal distal pole, and then it goes retrograde towards the waist and the proximal pole. And proximal pole has a very poor blood supply and less likely to heal than the distal pole. So important is usually the most importantly is the first and foremost is always the history of the fall. If history is such that wrist was in extension and radially deviated, then we must suspect a scaphoid fracture. Usually the most common telltale signs are anatomical snuff box tenderness, which is very important. Important is to where the pain of the patient is. If the patient is complaining the pain around the distal radius or radial styloid area, that is the point probably there could be radial styloid fracture or there could be associated scaphoid fracture as well. Usually the common mechanisms of normal test is the first anatomical snuff box tenderness, then is the Watson test in which we push it, give an axial compression. Other could be the ulnar distraction in which there is a tenderness over the anatomical snuff box, and there will be a simple tenderness over the tubercle and the snuff box. When we palpate the distal tubercle, if there is a fracture, that will result in tenderness over the scaphoid. The important point is to get the x-rays. As I told you, the most important views are the PA view with the ulnar deviation, and that is mainly actually this view results in exposure of the scaphoid, and if there is even a subtle fracture, that usually comes in in a view most of the time. Usually the 4 standard scaphoid views can be examined, but the most important is PA view with the ulnar deviation. Recent fracture shows only on the oblique view sometimes if it's not complete fracture. Usually the fracture line is transverse in the proximal pole. If it's a transverse or in the waist fracture, that is easily can be seen. But sometimes the tubercle of the scaphoid is fractured, and that is what happens is when the tubercle fractures, which is lying on the dorsal side, it rotating in such a way that it actually produces a circular ring sign, which is called as a ring sign, which is because there is a rotated distal tubercle after getting fractured. Usually, you have to look for the subtle signs of displacement and instability as well. This can be seen on Watson test as well and anatomical snuff box tenderness as well. The best is to get a repeat X-rays after 2 weeks. If there is a hairline fracture or a subtle fracture which is still not seen, probably at 2 weeks time that would be clearly visible. Now, why it is important? Because as I told you, there is high chance of getting avascular necrosis of the scaphoid. So to prevent delayed union and non-union of the scaphoid, we have to get a diagnosed scaphoid fracture early. If the union is delayed, the fracture line is more apparent and harder bone can develop, making it then an extra carpal bone, which is very easily palpable that this is probably is not one scaphoid, there are two scaphoid due to fracture. As the non-union establishes itself, there is usually appearance of cavitation on either side of the break, and this can be very clearly seen on the X-rays. If you see this X-ray, now this is the scaphoid bone, this is the radioscaphoid fossa. Very clearly, probably the X-ray fracture line is going transversely across the waist of the. This is the dorsal pole, this is the proximal pole, and this is the waist of the scaphoid. Usually, in the distal pole and the waist, this non-delayed union, non-union occurs. This is because the distal fragment is flexed forward. Now, when it breaks, the distal segment or dorsal segment is flexed forward while the proximal segment tilts backward. So there is actually angulated at each other. Proximal pole tilts backwards, and appearance of the round scaphoid tubercle on the PA view can be seen as well, which gives it a circular ring sign. Now, what's the treatment? On the lateral view, why we need to still get a lateral view is to just to look at the dorsally tilted proximal pole and the lunate as well. Sometimes this is associated with lunate perilunar dislocation as well. And scaphoid fracture is very common in occurrence along with the perilunar dislocation. So we have to treat the wrist as a whole. We just not have to treat one bone. So we have to get all the views. That is both the supination and pronation oblique views, lateral views, as well as the PA view with the ulnar sided deviation. So what happens when there is a non-union of the proximal pole? This may not lead to malalignment, but the problem is usually AVN happens and it results in a dissolution, a crumbling of the proximal pole. This leads to relative sclerosis of the proximal pole and pathognomic avascular necrosis. Now, this is the proximal pole which is actually attached to the lunate. So once this proximal pole becomes avascularized, or there is actually AVN of this pole, therefore the scapholunate ligament would be lost as well. So that also produces scapholunate ligamentous instability as well. So what is the treatment? The acute fractures, they're always treated in a cast for 4 to 6 weeks, usually without any complications. But if they're displaced or there is a non-union, then probably we have to go for some other kind of intervention. And that actually, if there is a proximal pole, a very small piece, that can be excised. But if it's a large piece, we may need to graft as well, because otherwise the union will not occur over there. And for that probably requires an open adhesion internal fixation with the screw fixation as well as bone grafting. Now, the treatment of undisplaced waist fractures can be around 90% given treated in plaster cast, and that has to be retained in for 6 to 8 weeks. And the wrist position is usually 30 degree of wrist extension with slight ulnar deviation. And usually we can re-examine the wrist joint after the cast removal. And CT scan is more specific just to see whether the fracture has healed or not. If there is a fracture is still healing, there is a delayed union, we can reapply the cast. But if there is a non-union, then probably we can go for screw fixation or internal fixation of the scaphoid fracture. That could be in form of percutaneous fixation, which is usually most commonly done for acute injuries. For those patients who do not want a prolonged plaster immobilization or want to get back to work a spot earlier, special cantilevered screw or technical fixation is required. This is called as Herbert screw or headless screw, which are actually inserted into the scaphoid, and under the guidance of a fluoroscope, they can easily be, once the fracture is reduced, and first convert a displaced fracture into a non-displaced fracture, and then a Herbert screw or a headless screw can be inserted into the scaphoid fracture percutaneously. But that is only usually it's called a CRIF, closed reduction internal fixation with percutaneous screw. But that is reserved only for athletes or those who want to return to sports early. Usually, most of the time, the patient is treated in the scaphoid cast, that is for 6 to 8 weeks. But if there is a non-union, then probably we'll have to go for open reduction internal fixation as well. Sometimes for the displaced fracture, they also can be treated in a plaster cast, but they have to be first reduced back to non-displaced fracture. And sometimes what happens is initial displacement was such that this has resulted in actually this, even the ones they're reduced back and plaster cast is applied, they do not heal very well. It's better to reduce a fracture if closed is possible, well and good. If not, then you have to open it up, reduce it back, and then apply a percutaneous pins and apply the cast as well. Because this is important. Once you open it up, it's better to apply a compression screw or percutaneous pins so that before applying the cast again. Otherwise, once the fracture was already displaced, we have reduced it openly, there is always a high chance that once you apply the cast only, there is probably a redisplacement of the fracture after a few weeks. Now coming to the proximal pole fractures. If there is isolated proximal pole fractures, as I told you, the blood supply is coming through the retrograde area from the dorsal pole, so there is a very high chances of avascular necrosis. This may heal in plaster, but there is always a risk of non-union. And disadvantages, usually the prolonged immobilization results in the wrist stiffness because they sometimes require more than 8 weeks, sometimes 8 to 12 weeks of immobilization as well. So if it's a proximal pole, it's better to fix with closed reduction internal fixation with the cannulated screw. What are the complications which may be associated with the scaphoid fracture? The first and foremost is always the avascular necrosis, especially of the proximal pole or of the waist of the scaphoid. Next is the delayed union and the non-union. The most other common could be the radiocarpal arthritis leading to continuous wrist pain during the normal movements of the wrist joint. In this section, we have briefly gone through the fractures of the scaphoid. The most important point is usually the mechanism is such there is fall on the outstretched hand, the wrist in extension and radially deviated. The first and foremost X-rays which can be done are always the PA view with the ulnar deviation. They usually tell the clear-cut tail signs of the fracture scaphoid. But if the fracture is not visible and there are chances that you are suspecting this fracture, you can still immobilize the wrist joint and repeat X-rays at 2 weeks. Important to note is that we have to realize it that there is always associated avascular necrosis of the proximal pole. Why? Because the blood supply of the scaphoid is actually coming from the dorsal pole, which may get disrupted, especially in the dorsal pole fractures. Thank you very much. Keep watching sqadia.com.